Welcome to AETCM, the Emergency Medicine Channel. 45-year-old male with no comorbidities presented to ER with alleged history of electric shock followed which patient fall from height, sustaining an injury to the right shoulder, and the patient also have a burn on the right forearm. Initial 10-second assessment, airway was patent with able to complete full sentences. There is no stridor, hoarseness of voice or soot on the airway, on the nostrils. Then breathing wise, respiration is 18 per minute with a saturation of 98%, bilateral air entry present. Circulation pulse rate was 80 per minute with a BP of 120/70, with all peripheral pulses palpable, S1, S2 heard. Disability, GCS was 15/15 with the GRBS of 200. So adjoint to primary survey, we also did the ECG, which was normal sinus rhythm with no STT changes or no arrhythmias, and VBC also showing no acute acid-base disorder with a potassium of 3.4.
Okay.
So history of presenting complaint. It's a 45-year-old male with no comorbidities. Apparently, patient was like using a sackle. Patient was cutting his the tree barks and branches of the tree.
Okay.
Allegedly, patient had mistakenly cut the line was crossing, and patient had electric shock. Post the shock, patient was having a fall, which was only 3 feet fall. Post which patient also have a right-sided shoulder pain.
Okay.
During fall, there was no LOC, vomiting, except from the pain. Patient was not having any chest pain, LOC, vomiting, headache, or any head trauma was there.
No bleeding also.
No bleeding or no other external injury apart from the right forearm. There was a burn. Then on examination, systemic examination, patient was conscious oriented with CVS S1, S2 heard with the bilateral air entry heard in respiratory system. There was no intercostal, there is no tachypnea or intercostal retractions. Circulation wise, S1, S2 heard with no murmurs. Then CNS wise, there is no focal neurological deficit. Patient was complaining of mild paresthesia on the fingertips of the right hand. Local examination, patient there were no exit or entry wound, but patient have a secondary burn in the forearm. There was no any active bleeding from any other apart from any other area. On the right shoulder, where there were restriction of movement, and Dugas test was positive.
Okay.
So we did since it's an electric shock, and most probably the most common complication of electric shock include arrhythmia. We did an ECG. ECG doesn't show any arrhythmias, and there is no normal sinus rhythm only. VBG also showing there is no acid-base disorder, and potassium was also normal. We did a X-ray shoulder, which was showing a posterior dislocation of shoulder, which we corrected by we corrected by external rotation, and externally corrected, and we put a shoulder band.
Okay.
So our impression is a burn secondary to electric shock associated, and due to the fall, patient had a right shoulder dislocation, posterior
shoulder dislocation. Okay. So we have a 46-year-old male who was apparently attempting to clear off some branches of a tree, and accidentally his instrument came in contact with an outside electric line, and the patient had a fall associated with also a burn secondary to the electrical shock, and also a shoulder dislocation was there, right? So electrical injury is a concerning concerning problem in these days, especially during the monsoon season. When there is wet conditions, and also the winds can cause the power lines to fall off, and people accidentally come in contact with it and cause a lot of casualties. So we should be knowing thoroughly about how to manage them in the ER, and also outside the hospital how we are supposed to approach these cases what to look out for. Sometimes if we were lucky in this patient because he was conscious oriented at presentation. Sometimes these patients are not conscious and oriented, so we'll have to presumptively judge that these things might have occurred, investigate accordingly, and then come to a conclusion and treat the patient. So electrical injury, the electricity that passes through a body depends, or the electric current that passes depends upon the potential difference, the difference between 2 points, right? And it is directly proportional to the voltage, and it is inversely proportional to the resistance. Basically, any electrical injury, the injury that is causing all the issues is mainly because of 3 different subsets. First one is because of the electricity itself. Second is because of the resistance which produces heat and the thermal injuries associated with the electricity. And third is the mechanical injury that follows. All right. One thing that we should realize is always whenever there is an electrical injury, the circuit has to be completed. Like the patient, the person, might be in contact with the electrical power source, and say the power source, there is a voltage criteria also. I'll get into it. So if you are in contact with that, and if you're grounded, that means it completes the circuit. All right. But say if you're standing on a log of wood, which is very dense and is an insulator, and the source of the voltage is on the lower side, then the circuit is not completed and the patient doesn't get electrocuted. So this is something that we should know. In our houses in India, the voltage supply keeps differing across countries. US it's different, Europe it's different. In India, the standardized this would be 230 volts for a single phase. Normally in our homes is what we are talking about. When it comes to bigger industries or big homes or mansions, what they have is they have something known as 3-phase supply. There the voltage supply might be around 410 volts or above. All right. When we go to bigger industries or also the railway transmission systems and all, there it is in kilovolt. It goes up to 66, 450 and all kilovolts. So the energy keeps increasing. High impact electricity injuries can be termed as more than 1000 volts, and the low is less than 1000 volts. Anything more than 600 volts is considered clinically very significant. All right. But at the same time, we should remember that electricity can be of 2 types. Alternating current is there, direct current is there. What we get in our supplies is always alternating current, AC. So AC current at a low frequency, all these are supplied mostly at 50 Hertz, frequency 50 Hertz. But low voltage AC supply at 50 Hertz can also trigger life-threatening arrhythmias, cardiac arrhythmias. Like for example, the patient might present with ventricular fibrillation. And also at the same time, low frequency, you should be careful that the patient, when he's holding the iron rod or something which is connected to a electric pole or electric source, there is your hand can go into tetany. And tetany at this low frequency, what happens is tetany makes sure that the patient is grasping the object and cannot be left immediately. So that is another issue for it. Any electrical injury, the magnitude of the injury depends on the amount of current transferred, the duration till which this happened, and also the magnitude, of how impactful the injury is. So depending on that, it is classified. So one of the most important things with electric injury is also that the way it presents to you, right? So say for example, the patient is in contact with the electric source and he's grounded, right? Okay, say my right hand is in contact with the electrical source and I'm grounded right now. The electricity always takes the path which is of the shortest distance and also least resistance. In our body fluids has more of fluids and electrolytes in it. So they are better conductors. While dry substances like our bone, these are bad conductors, or you cannot call it insulators, but they are bad conductors. So our vessels and nerves and all that are perfect conductors for it, while your bones are not. So when coming back to the scenario, say my right hand is in contact with the electrical source and I'm grounded right now, the pathway that it takes is very important because it will give you an idea regarding what the extent of the injury is, or you can predict what all injuries the patient would have had. So if I'm holding it this way, the easiest path possible right now is from here to my right leg. So it is passing from here, it's passing from my hand to the leg. Okay. So everything in between this, your muscles, your diaphragm, your heart is also involved, and your legs. This part is involved. You might or might not have an entry and an exit wound. Entry wound is smaller, mostly smaller than your exit wound. That is something you should know. Say if it was hand in hand, then you should realize that if it was in contact this way, it would pass in this direction. So you'll have a more impact on your heart. All right. Now something was in touch with my head and I'm grounded. Then it is going to pass this way. So I'm supposedly expecting more of CNS symptoms in these patients. Right. And one thing that they say is if the patient was in contact with a low voltage electric source, and on initial presentation the patient's ECG was normal. I'm just talking about cardiac criteria here. If ECG is normal, then there's very less chances that the patient will develop a cardiac dysrhythmia, and he doesn't require admission for cardiac monitoring alone. For something else you can admit him, say for acute kidney injury or something you're suspecting because of myoglobinuria, you can admit the patient, but for this particular reason you need an admit. All right. Now what happens is there are two rhythms that can happen when it comes to the heart. One is your ventricular fibrillation. The second one is asystole. Okay. Now this is totally, it's clinically very similar to your cardioversion that you do or your defibrillation. It is basically stunning the myocardium for a brief second. It's rebooting the heart. Once the shock passes away, the heart starts to bump again. But one thing that we always notice, whenever there is a asystole or a ventricular fibrillation, life-threatening rhythm, the cardiopulmonary resuscitation should be very adequate, should be done, because the myocardial damage that would have happened might be very insignificant. Okay, so you can bring back the patient is what I'm trying to say. All right. So we discussed that, and when it comes to the presentation of electrical injuries, if we can go from head to toe, could you please enlist how the patients can present?
So the patient will be presented as from head to toe.
Say from
CNS, there will be impairment. If neurological impairment with electric injury in approximately seen in 50% of patients.
50% of the patients.
So always we have to make sure patient have a thorough CNS examination prior to sedate the patient or intubate the patient. So if a patient patient is presented with a transient loss of consciousness or followed by a seizure, we have to get a CNS imaging done to rule out any other causes of CNS, like any trauma or any infarct or anything. We have to rule out.
All right. Because it can be secondary to the electrical injury itself, or because of the mechanical injury sustained later. So you should rule out bleed or anything. The patient can present with multiple things.
Transient neurological loss of consciousness or focal deficits like quadriplegia, paraplegia, hemiplegia, or visual disturbance could be there.
Most of the times the patient might present to you in either a confused state, like a post-ictal confusion, how they present to us in a confused state, or the patient might be agitated, or sometimes the patient might be actually comatose or drowsy. And then spinal cord involvement happens in around 8% of the injuries. All right. So, these patients also, the spinal cord injuries are mainly because of either spinal artery thrombosis, aneurysm, and also it can be because of dissection itself. Also, it can be because of the vertebral fracture, which can later lead to a cord compression also. So the patient can present with so-and-so deficits. Sometimes this might not be initially visible in the MRI. So that is something that we should keep in mind.
So always make sure we have a patient with a C-spine stabilizer if a patient presented to you with an electric shock. Until and unless we proven that there is no fracture, we have to take it as a fracture only.
So that is something that we should always remember. C-spine and also whole spine immobilization is ideal for these patients. Right?
Because due to electric shock, there will be tetanic contraction. Contractions can cause fractures in the spinal cord. That can in turn cause compression and quadriplegia, hemiplegia, or other neurological deficits.
You don't want to worsen it.
And then CNS, there will be ocular, like from head to toe. There will be ocular injury we can suspect if the patient is presented with a visual disturbance post electric shock, and so a thorough ocular investigation should be done. And cataract can be a delayed complication.
So one
of
thing that they
electric shock.
say is one of the most common things that you miss, few things that you miss in electrical injury is that ocular injury, ear injury, auditory injury, lungs related injuries, and GI system involved injuries. These are something that you might miss. So ocular injuries, they say that baseline examination should be done and the values should be noted and kept, because these are not going to form all of a sudden. These are mostly late complications, can develop over a couple of months or years. Cataract and all might develop a little later. So that is very important. That should be noted, right?
Then ocular either due to occipital lobe injury or due to optic nerve injury. Late complication include cataract can also occur. Then auditory injury,
keratitis, so many issues are there, right?
Then auditory system, there will be there is damage by either current or by the hemorrhage in the tympanic membrane. Delayed complication can also occur like mastoiditis, sinus thrombosis, meningitis or brain abscess. Then hearing loss may be either immediate or can be a delayed complication. So a thorough hearing also should be documented in our ER note.
Yes.
Then as hearing, then it will be cutaneous nervous system can also get. Peripheral nervous system injury can also occur because of the low resistance. This current flowing to nervous system is more common, damaging the pathway. Either the cell membrane can also damage, or the either like palm neuropathies can also occur, or the transient lows can also occur. Some nervous neuropathy, some transient lows can take even years to resolve itself.
What are the common neuropathies that can happen? Which nerves can commonly get
median nerve and brachial nerve are more common than radial nerve.
Okay, radial and ulnar. Right?
Median and ulnar.
Median and ulnar. Okay.
Than radial. Brachial plexus can also get involved.
All right.
Then as we go on, then cardiac are the most common complication post electric injury, and there will be asystole, which can or ventricular fibrillation, usually prior to the arrival of ER, and any asymptomatic patient with a normal ECG after presenting to ER they will be unlikely that the patient can go into ventricular fibrillation. So myocardial injury can also occur due to vascular damage, like after electric shock, our vessels in heart can cause into spasm and ischemia or dissection, which can later develop to MI. Then next is cutaneous burns can also occur.
Right.
Like burns, either exit wound, entry wound can occur in case of DC current, or contact wound in case of AC current. So any burn, usually burns are painless with grey to yellow color, yellow depressed area. Most patients with burn should be referred to an higher center with burn unit. Then orthopedic injuries are very common, either due to tetanic contractions that can cause fractures, and also dislocation due to the blunt trauma.
Blunt trauma as well. What is the most common dislocation that you see?
Shoulder dislocation, posterior
shoulder dislocation. What are the most common bones that can get fractured?
Fractures from the wrist, forearm, humerus, then femoral neck, then C-spine, then scapula, every has been reported.
Right. So basically, why are we discussing this? These are things that you are supposed to know look for in the patient. Maybe the patient, if he's unconscious, you might not take it very seriously, but you are supposed to take a look at everything ideally, but these more specifically you're supposed to look for. Right.
So vascular and muscle injury is very common. So vascular and muscle injury is more common with the high velocity injuries. As current passes through the peripheral artery, they can cause spasm and also persistent deficiency in endothelium and smooth muscle function. Subsequently, thrombosis and stenosis with or aneurysm formation can also occur. These this vascular injury along with muscular necrosis due to the current flow can lead to compartment syndrome.
Compartment syndrome, right?
Which is seen only if current should be, that can also develop even the current is flowing less than 1 second. But more commonly, more than 120 volt AC current is more common seen associated with compartment syndrome. So the most common presentation will be painful movement of limb. So if compartment syndrome is there, we have to do a fasciotomy if signs of compartment syndrome is there.
How are you going to monitor whether the patient is going to develop compartment syndrome in the ER?
Peripheral pulsation,
yes.
And pallor, and
you can check for the capillary
reflex. Or the patient is complaining of pain with movements.
Increase in pain.
On the compartment pressure, we can also check.
Compartment pressure, although not routinely done, but it's something that we are supposed to do.
Then the circumference of the limb.
You're supposed to check a note of every hourly or how many duration frequency you want. Accordingly, you're supposed to check the width of the limb, right?
Then in high voltage injuries can also causes rapid loss of body fluid, or burns can also cause body fluid. So rapid resuscitation with fluid is also indicated. If the patient is also presented with myoglobinuria, we have to suspect rhabdomyolysis, which can also treated with aggressive fluid management.
Okay. What is the targeted urine output that you check for according to ATLS?
1 to 2 ml per kg per hour.
1.5 ml per kilogram per hour. Till the urine myoglobin is gone or normal. The discoloration is improved, right? Okay. So, Rima, I guess we failed to mention a bit about the pathophysiology. What all are the electrical arc injuries?
So electric injuries. Electric injuries.
How can you classify the electric
injury? Right. Electric injury can be classified as high voltage injury and low voltage injury. If it is more than 600 volt, it's considered as a high voltage injury, and less than 600 or more than 1000 high voltage, less than 1000 low voltage injury. So this injuries can also causes severe as sir already told, it can be either due to electric charge or to the burns or due to the blunt trauma secondary to the blast kind of feature in the
secondary to because the force that the patient sustains
will
after during the fall.
So then there will be cutaneous burns are more common with high voltage injury.
Right.
Then there's a thing called electric arc injury, where we won't have a direct contact with the electricity, but the electricity will form a magnetic field. That field can cause a blast kind of injury.
So basically, in electrical arc injury, this happens when high voltage transmission is happening, especially in big industries or mostly in the railway transmission lines. So they are kept very high above us for this reason, that you don't want to get into the electrical field, because when you move there, the electrical field transiently is disturbed. Now there is a blast of electrons into the air. It gets dispersed and the air molecules are dispersed, and this sudden rapid rush of electrons, electric current would make the matter change into plasma. Okay, so plasma has a lot of heat, and this heat is getting transmitted. It is not the electric current, it's the heat. So basically the injury can be divided into the plasma heat that is being transferred, plasma molten metal spray it's called, heat exchanges there. You have UV radiation from this, and also you have a blast kind of energy coming from it. So this is going to cause a lot of havoc to the human body, mainly the burns. Second, the blast itself can cause a lot of ruptures everywhere. Starting from your globe, you have globe rupture, you have tympanic membrane rupture, you have lung barotrauma, you have GI visceral perforations that can happen. So all this is what electrical arc injuries are about, right? Next
is tetanic contractions of the muscles.
Tetanic contraction, that's something that we discussed. Basically the forearm and the fingers are involved, the hand muscles are involved. It overpowers the extensors, the flexors are more involved. So you kind of grasp everything and hold for a long time, so you get more electric current inside you and causes more damage, right?
Then, as we discussed, clinical injury. Other include blast kind of injury and inhalational trauma to the lung. After electric injury, chemical toxins like ozones can be produced by the coronas and cell arcs in the electric field. This can acute effect of ozone exposure include mucosal irritation
mostly.
then reduced temporarily reduced pulmonary function and pulmonary hemorrhage and edema. Then this fire and expulsions secondary to the electric incidents can also cause inhalational injury, inhalation of carbon monoxide and other
That
toxic
is something that we can miss. Carbon monoxide poisoning and electrical injury. It's not just because of the electric injury. The electric current is going to cause a fire somewhere in a closed room where this person was, and it might cause carbon monoxide injury. So co-oximetry should be tested in such patients, right?
So some coagulation disorders can also seen secondary to the tissue necrosis and thermal injury, and the low grade DIC can be suspected as a result of hypoxia, vascular stenosis, rhabdomyolysis, and release of procoagulants.
Right.
Then ocular. Then pre-hospital we have to scene safety.
Scene safety.
Scene
How are you going to approach this patient?
So first we have to at least stay 10 meters away from the power, drawn power lines.
Where this happened, the scene 10 meters away. Right.
Then we have to turn off the power source.
If possible, turn off the power source.
And if it can't be turned off, we have to take precautions to prevent
We'll
the
have to
electric
wear
shock.
industrial grade gloves
And shoes.
and helmets and whatever is required so that you don't get electrocuted.
Initial rescue breath and resuscitation effect while an injured patient is still on the pole can be given, as well as the spinal immobilization we have to maintain.
Yeah.
So the victim, if the victim is still in contact with the voltage in the current source, he had the tendency to pass that current to the rescuer also. So we have to scene safety is very important.
Because say the common notion for everyone is to use a wood to remove the patient, but I guess in voltages above 600 volt, wood can also conduct the electricity. So it's not safe to use wood. So you should know the power source as well.
Then the low voltage AC current can also produce ventricular fibrillation or ventricular cardiac arrest. Asystole. After severe minutes of asystole, respiratory muscles can also go into paralysis. So with CPR, we may get our heart rhythm back, but due to prolonged respiratory arrest, that's a cause of apnea. Like respiratory apnea, we have to take care also.
That's why they say that before you can administer CPR,
we have to give
you can give the rescue breath. Before giving cardiac compressions, you can start giving breaths.
Then we have to
Once the patients arrive,
we have to fluid resuscitation should be done according to Parkland formula.
How much is that?
That is 4 ml per kg per hour over 24 hours.
4 ml per kg.
4 ml per kg multiplied percentage of burns
surface area
per
by
the body
16 will give you ml per hour. Alright, so you can give that. And you target a urine output of 1 to 1.5 ml per kilogram per hour.
So then according to us, if you are suspecting rhabdomyolysis or myoglobinuria, we will resuscitate with fluid. Then peripheral central CNS defects is there, like focal neurological defects is there. We'll get an MRI or CT done to rule out any traumatic injury.
And the low threshold for imaging, neuroimaging. Yes.
Then
EFAST can also be done. Then skin, in case of skin, we have to assess and treat the skin burns, cutaneous burns. Musculoskeletal, we have to do a careful assessment, and X-rays, if indicated, we have to do, and assess for compartment system, and if needed, fasciotomy should be done. Then vascular spasms can also cause delayed thrombosis, aneurysm, and muscle damage. We have to keep in mind. Then coagulopathies have to be treated by eliminating the precipitating factors. And lung inhalation, assess for inhalational trauma, carbon monoxide poisoning, alveolar injury due to the blast. Then eye and ear, we have to do a thorough eye and ear examination. And the baseline findings
and delayed cataract can also be present. Then GI intra-abdominal traumas and perforations we have to keep in mind in case of any abdomen tenderness or abdominal pain. So in case of child, they have
two subsets that you're supposed to keep in mind, like you started, is pregnant females and children.
Children, especially
pregnant females, which gestation week of gestation?
20 to 24 weeks.
20 to 24 weeks of gestation. If they get electrocuted,
we are
supposed to check for uterine contractions, and also fetal monitoring should be done at least for a period of 4 hours. And in case of pediatric injuries, what happens is mostly lip and oral burns are very common. So there's a very high chance of labial artery spasm can happen. And also because of this, bleeding is very common up to 2 weeks after the injury. So the parents should be counseled. And also at the same time, it can give to restriction of movement of
Scar
mouth opening
formation.
and all that because of scar formation, for which proper splinting and physiotherapy should be done, and the parents should be counseled as well regarding the same. Anything else that we have to discuss? I guess that winds up the discussion.
Okay, thank you.
Thank you.